सरस्वती महाभागे वर्धे कामरूपिणी विश्वरूपी विशालाची विद्या दे परमेश्वरी सरस्वती मया दृष्टा वीणा पुस्तकधारिणी हंसवाहिनी सहिता विद्यादान करो ममः। ओम शांति 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 ही अस्तु. Now, let's start our second day of this conference with our keynote lecture on Where is my stethoscope by Dr. Hemant Antani sir. Dr. Hemant Antani, MD Medicine from Baroda Medical College, postgraduate diploma in diabetes management from Middlesex University, UK. Practicing consultant in field of diabetes and non-invasive cardiology in internal medicine in Anand Gujarat at Orphan Hospital and ICU. Chairman Ethics Committee at Akanksha Hospital, Anand. Member of American Diabetes Association and American College of Cardiology. Life member of various national and international academic bodies. He is also a motivational speaker in giving lectures on happiness, attitude, time and stress management from many years. Sir, I invite you.
Good morning. Is it a Saturday blue? Good morning. Well, the topic is where is my stethoscope? Abhishek, my title should be where are the delegates? Well, I can understand it's a Saturday evening. Nevertheless, I thank the entire Criticon team for inviting me and share my experiences of 38 years and be amongst the most vibrant group of medicine, that is critical care specialists. So let me start my When I say where is my stethoscope, what it means is it's a metaphor. It's a metaphor for the clinical skills. It's not exactly the stethoscope per se. And I'm sure you'll realize as I'll go through the entire presentation. So before I start, this is my disclaimer that I'm not immune from what I'm going to talk about. The observations are general and do not point to anyone in particular. So I do not intend to preach. So friends, this is basically an introspection for all of us, for you, for me, for everybody, those who are practicing medicine today. And this journey we are going to take together. And at the end of the lecture, if we think that we have got something to ponder on, something to think about, then I think I have done my job successfully. Well, my enchanting journey of last 38 years, I did my MD in 1984 from Baroda, has been through many joyous, trying, and at times very frustrating moments. And in fact, I've been lucky that in 38 years, I've seen a lot of metamorphosis in our medical practice. And in fact, I'm still witnessing, even at a faster pace than what it was 10 years before. But before I start, I have always wondered why we call what we do as practice. That actually sums up that how good we are in managing our profession. So let me start with history. I mean, those who belong to my generation or those who maybe a little bit one generation down would definitely remember the importance of history taking. In fact, when we were doing even undergrad, I think history taking was such an important thing to be done. So once considered an art, unfortunately, history is almost becoming a history. How much time we are giving to the patient just before we begin, with a lot of enthusiasm, the managing the patient. The time does not permit me, but I can give you at least 50 examples of where the right kind of history did the job and wrong, not taking history led me into the soup. In fact, I have committed many mistakes. I mean, there's no question, and that's how this entire presentation is. So, for example, you will see that a patient who comes with fever, a patient who comes with dyspnea, a patient who comes with jaundice, you have to give some time. For example, the patients who are on AKT will not tell you. It's unfortunate. Many times people don't tell if they are not asked. And the patient is being investigated for autoimmune hepatitis. This is not a fiction, this has happened. And the patient was on AKT, nobody actually unearthed that particular history. So point is that it's very important, as a critical care guys, when the patient of dyspnea comes to you, I understand you have to manage immediately, But at the end, you also have to give very much importance to the history. I tell you, and this actually is the TOS data, that hardcore data, which shows that physicians are able to collect, and I'm fully on the page with what exactly is being said here, is that physicians are able to collect 60 to 80% of the information relevant for a diagnosis just by taking a medical history, leading to a final diagnosis in more than 70% of the cases, which has come in International Journal of Medical Education. And I'm sure all of you would definitely agree with this. And if you do agree, why don't you find time to ask the patient the relevant questions? And I'm very fond of William Osler. In fact, all those young boys who are here, young girls, those who are pursuing your career, please read William Osler. You must. If you really want to become a very good doctor, you must read William Osler. And actually, he has come up with so many good points to ponder on. And one of the important things which he says is, listen to the patient. He's telling you the diagnosis. In fact, it is true. I remember Dr. B.T. Dave, a very famous teacher in Baroda, who erstwhile he was a Sheila Shylock student. And the way he would narrate that the history of acute left ventricular failure from the patient, or get the patient from the patient, it was just nothing less than a poetry. I tell you that history is something very, very important. So listen to the patient, and he's telling you the diagnosis. I would strongly recommend you, all of you, to read this book if you are not. This is by Lisa Saunders. It's a wonderful book. All of you must read. Every Patient Tells a Story. It's a Medical Mysteries and the Art of Diagnosis. A wonderful, wonderful book. Everybody says that history clinches the diagnosis, or history actually takes you on a right path that I'll tell you further. But do we really care to listen? That's a question mark. All of us have to ask ourselves. We are too busy, our volume load is too much. These excuses are not in the place. And then, how many of you now do this? I still remember in a case presentation, you had to go through inspection, palpation, percussion, and auscultation. Because there was an importance of clinical examination. But this is almost getting obsolete. Now, when the patient comes with dyspnea, the first thing, get X-ray, and if you get CT scan, get the pro-BNP, and so on and so forth. I mean, you don't give time to the patient to listen to him and then properly examining him. I think this is very, very important. I still remember one of my very close friends. She is in the US for 30, she was my classmate. And she had to say this, which actually I was pretty ashamed. She said that, Hemant, I took my mother in Baroda to a couple of, super specialists for some problem. And I was surprised that nobody put stethoscope on my mother's. They just asked some questions and said, okay, wow, fine. So why you guys are not examining the patient? So this is really come from one of the, senior most cardiologists from US. She is my very close friend because she's my classmate. So this is something which we have to ponder on. Now, if you see further, this is in a recent study in USA, Canada, and England. It was found that the correct assessment on auscultation was made in only 22, 26, so maximum 26% of the time the doctors could talk about auscultation. And once again, I remember Dr. B.T. Dave. All those who were in Baroda would remember that he would mimic the murmur with his, mouth. The ejection systolic murmur, the holosystolic murmur, the mitral stenosis, late diastolic murmur, and opening snap, and everything he would say. So actually, this is so important. And let me give you one example, because once again, as I said, any patient of dyspnea is not COPD. Any patient of dyspnea is not just respiratory in origin. I tell you, many a times it happens that a patient is first labeled as COPD, goes from pillar to post with the same breathlessness. Most of the times, I'm not saying that everybody does that, but this I've seen, that it was not a very big rocket science, but if somebody had put the stethoscope, there was a severe aortic stenosis. In, I think, at least 4 patients I remember. So the point is, it's not that somebody is very smart, but somebody is sincere. I think that's very important. So if any patient comes to you as a second or third consultation, just, wipe off the entire thing before and start afresh. See the patient. I think it's very, very important that you should do. A patient of herpes zoster coming with the chest pain to a doctor, he does not even bother to see, get the ECG done and see, and the nurse comes and says, doctor, there is something on the chest. Would you like to come and see? He goes and says, it's a herpes zoster. ECG was not needed. So the point is that you have to examine. The rashes, for example, nobody actually takes up the clothes and finds whether the patient has got rashes or not. It's something which is very, very, very important that you should always remember. So I always believe that the technological advances, I'll tell, they are absolutely important. They are fascinating. They are beautiful. They have helped us a lot. But it has to have a foundation. And this foundation is clinical science. So ignoring a basic clinical science is like constructing a big building without strong foundation. It is not going to survive. I think I remember one of the lecture yesterday, Dr. Srinivasan, the point of care ultrasound. I liked what he said, that ultrasound is good, but at the same time, the most important thing is you have to be clinical. I think it was driving the point. So you just can't do ultrasound without your clinical feedback. And that's the point that I'm trying to drive at. So what happens? Why I'm focusing so much on history taking and medical examination. See, what happens is that if you are taking a good history, if you are examining the patient properly, and if it does not happen, what will happen? Delayed diagnosis, because you are on a wrong path. Unnecessary and potentially harmful treatment, needless testing, escalating medical costs. I think there was one question which was asked by, I think, Dr. Gopal Rawal yesterday, how do you reduce the cost? And one of the answer which I really loved was somebody said that you should be very careful about ordering the investigation. Wonderful answer. And I think that's something very important. Use your common sense. And potentially life-threatening consequences. And I think most important thing is what I'm saying in the last. If it is not addressed, this clinical examination, the most important, the most damaging thing which will happen in our medical practice is there may over be time a dramatic loss of value which is associated with positive patient-doctor relationship. I think this is most important. Nobody should overlook this. The problems that we face today is a different topic altogether. Someday we can discuss. Is a lot of fingers are also pointing to us. If we are pointing at the society, some fingers are pointing at us as well. So I think, this relationship is getting killed, and I think it's a very worrying part. So, I say a well-elicited history, thorough clinical examination, relevant investigation, lead to correct diagnosis. And friends, this is nothing less than clinical poetry. Ek kavita thi kashu oshu nathi aa, which we are creating every day. And these poetries are wonderful because it's different in every different patient. Who gives you this, particular opportunity to create this kind of poetry? But only point is, you have to have the pen in your hand and write it. That's something very, very important. So let's come to investigation. Nothing against. In fact, I would, when I say this, I don't want you to go home with that message that I'm against investigation. In fact, investigations are wonderful advances which have happened. Nothing wrong with it. But the most important thing is that, are we not overdoing? Are we not over-relying? The point is that investigation is there, but if we are overdoing, procalcitonin every day in a patient of bacterial infection, does it make any sense to anybody? It doesn't. Getting X-ray every day in a patient who is already stable, does it make sense to anybody? But yes, if patient is worsening, maybe 3 X-rays a day, okay, no problem. So my point is that you have to be very judicious when you are ordering investigation, which is going to be relevant. And sometimes we actually treat shadows. A shadow on an X-ray does not mean that patient has a problem. So over-reliance on technology has also created lots of problems. So this is what is happening. You are at a teaching hospital and hence all the tests. You have to do that. Now, this is happening. This is on a lighter vein. Don't take it too seriously. Nurse, get on the internet. Go to surgery.com, scroll down and click on the "Are you totally lost" icon. A technology. Problem is once again not. My always point which I really want you to go home with is The problem is never the technology. In fact, technology is something which is very, very important, very, very good. But very important thing is how you use it. A mobile, a social media. It has a good point, has a bad point. It depends how you use it. And the same thing is for our medical practice. So friends, technology, if you use very smartly, you are a very good doctor. And ultimately our role and our job and our objective, our mission and our passion should be to make our patients better. And that will happen only if we use this kind of attitude. So we should be judicious in ordering and interpreting the investigation. We should be master and not the servant of the technology. If I have to address one thing, this is what the message I want to give. Don't become the servant to the technology, become the master. And in fact, addressing the foundational issues of efficacy, equity, and cost effectiveness in our health system will require us to beat the addiction to technology. Now we have become so much addicted that we just don't want to apply mind. Get the CT scan 3 times, get the MRI 4 times, get these, just keep on doing it, but we just don't apply our mind at a time when it is required to be applied. So addiction to technology is bad. Smart use of technology is the best. So, this is also once again a statistic which is really mind-boggling. Some experts estimate that $200 billion wasted annually on excessive testing and treatment. Isn't it a point to ponder on? And there was a survey, and I'm sure this is just one survey. If you do survey, these figures might be even more. That 22% of the prescription medication, 25% of the medical tests, and 11% of the procedures were not unnecessary. So I think this is something very, very important that should be kept in mind. And as I've always been saying, we are almost doing something like this. If you are laughing at this picture, in fact, we are doing it. Common sense is becoming very uncommon. And that's the biggest problem that we are facing with the technology. The common sense has to even find a more pertinent place in our practice. And I think this is what I tell. So many young doctors come to me and say that, sir, what is your advice? I always say that don't end up treating the reports. Treat the patient. I would repeat for all the youngsters who are sitting here. Don't end up treating the reports. Treat the patient. I think it's very, very important to keep it in mind. Because if you start treating the reports, I tell you the consequences are not going to be favorable. And this is what is happening at the end of the day. Do you think that anything is left? And she says, still let's do an X-ray just to be sure. So this is not something which is, if it is a laughing stock, we do it day in, day out. Now come to the use of medicine. There are a lot of things which we can say. Medicines, all of you know that use, of course, I should have used the word use, but this is basically, it's a, introspection. It's either abused or it is misused. All of you know that and you would definitely agree. No need to go into the greater details. And I think this is what is happening. I have some very amusing experiences. As a senior person, we are called to see some patients seen by other doctors. And we find that a lot of personal fancies, આ તો મને આવી રીતે જ ફાવે. આ ટ્રીટમેન્ટ હું તો આવી જ રીતે કરું છું. There is no data, there is no support. And I think that this is something which is not very healthy. And I think we hardly look at drug interactions. Have you ever looked? Put your hands on your heart. And when you're writing so many medicine, especially in ICU, are you thinking about drug interactions? Perhaps no. And the next statement which I'm going to tell is, I know it's going to shake you up, and I'll actually say what exactly I mean. Everything is fair in love, war, and ICU. Now, when you say everything is fair in ICU, there are so many critical experts here. I have something to ask you. I understand that patient is dying and you want to do everything. But writing 8 antibiotics, does it help? 8 antibiotics, friends, I've seen, just to be sure. Now, what do you want to be sure about? 8 antibiotics. So many things that you can think of. So yes, you have to be very active in ICU, I don't deny that. But in ICU also, Just everything is fair in ICU and you can do everything is also not correct. But their logic and common sense, in fact, is required more in ICU than in your day-to-day practice. And that is exactly what I'm trying to say. Now, this is very important. It's, of course, Peter Drucker, those who are into reading, is a very famous author. We are looking for the right answers. But the problem is that we are asking the wrong questions. Friends, I really earnestly request you, for example, a person who has got a shadow, what points are coming into your mind which are relevant is asking right questions. If you don't ask the right questions, you will always be in a wrong path. And that's why it's very important that you inculcate this attitude of asking the right question, be it medicine or be it life, be it relationship, be it trust. You have to ask the right questions. And I think this is what even the senior people should teach our students, to ask them the right questions. It's very, very important. And knowledge versus wisdom. If everybody knows that tomato is a fruit, right? That's a knowledge. But the wisdom is that you can't put it in fruit salad, can you? So it's like, having a knowledge is something else. But whether that knowledge, how it has to be applied in the patient, seeing the shadow, whether that is responsible for a patient's problem, is a wisdom. Knowing that there is a shadow is a knowledge. So I think that is something very, very important that you must develop. And so what happens is that if we are into this, either we miss the diagnosis or we misdiagnosis, it's almost up to 30%. And Institute of Medicine reported that 98,000 people die each year due to hospital mistakes. 28% misdiagnoses are life-threatening or life-altering. Misdiagnosis and diagnostic errors make up about 10% of patient deaths and 17% of adverse events. So it's a huge number, isn't it? And now the most important thing which I really want to say, and this is something which is a crisis according to me, and I don't say that we are only responsible, but let's see what we can do from our side, because we just can't control the society. The only equipment lack in the modern hospital, somebody to meet you at the entrance with a handshake. I think this is very, very important. We have become robots. I know the society is also forcing us to do that. There's a debate. I think yesterday Bhalandu said something wonderful, that after the patient dies, we just don't treat him as somebody, it was my job, it was bad event. He said, you just stand and do the prayer. This is unbelievable, isn't it? If you can put this emotional quotient in you as a doctor, which you are supposed to, because you have decided to become a doctor. So you just can't keep on comparing your profession with the other profession of the world, where the emotional quotient is not there. So you should do what you should do. And I think lack of transparency. Friends, I think this is very, very important. If you ask many, disgruntled relatives in this 38 years, what I've seen is that they are sometimes not happy because the patient died. They are unhappy because nothing was told to them. Is it happening or not? That they said, patient died, but हमने कांई ज खबर नहोती क्या શું થઈ રહ્યું છે. And I think this is a very common story. The seniors are doing their job, and this is for the youngster. As I said, I was talking Abhishek, this is for the youngsters, because we want you to be what you should be. Because all the seniors yesterday said that some of the things the seniors should take in hand, when counseling but I think this counseling also should come from you. Your nature, your behavior, everything has to be in sync with why you are a doctor. Remember that. And if you do not, you remember this famous, right? That you have nothing to worry if you have nothing to hide. The youngsters won't know this was Monica Lewinsky and Bill Clinton. So you have nothing to worry if you have nothing to hide. But if you are hiding, you have got everything to worry. And that will be burnout. That would be stress. And I tell you that this is something very, very important. I think, as I've been telling this, Bharat and Gunjan, everybody is here. We had a very strong association in Zydus. And I always used to tell these boys that most important thing is not just treating the patient, but the family of the patient. And when you say family of the patient, it's a communication, communication, and communication. I think this is I'm sure many senior people who are sitting here, Lakhani Sahib is sitting here, you would agree that this is one of the biggest problems that we see from the younger generation. So please don't disappoint us. Communicate properly. And when you say communicate, either there is no communication, or there is a miscommunication, or there is a complex communication. You can see in the left side, this particular, what do you get out of this blackboard? Nothing. So you have to get down to the patient level. You are talking about ARDS and all those things. You have to make it simplified. Don't make it complex for the patient, so relatives. It's very important. And problem is that we listen to reply. We don't listen to understand. If Abhishek is saying something, I want to reply straight away to make him, feel wrong. No, I don't. I have to understand what he's saying. Let you understand and sink in what the relatives are saying before, but we just want to reply straight away. We actually sometimes cut them off. And information is giving out, while communication is getting through. And that's why the communication is very, very important. Ethics. It's not that. I'm telling you. I think this is what the society has created, that norm. When you say ethics, what it means is that it's in your hands. It's not that you cannot do it. And market forces push up the excessive use of medication technology and devices. Something to be worried about. The escalated use of these modalities, many a times unwarranted, leave a lot to ponder. This is a point which I'm throwing open for you to understand, for you to take it further and make that our practice becomes more ethical, more patient-centric. And this is my observation over 38 years. The clinical is going down, investigational part is going up. The personalized approach is going down, commercial approach is going up. But I'm not against it. But then there has to be balance. There has to be common sense. There has to be some purpose why you are a doctor. I think it's something very, very important. And I think your conscience, it's very, very important. I always say that, somebody says that, why we should do it. I always say that, are you not accountable to yourself? You have to be accountable to yourself. And that is what the conscience is all about. And always remember, which I have to say here, is there is no right way to do a wrong thing. You just can't justify any wrong thing that you do. There is no right way. Remember that. And very, very important thing is, I think we are missing a lot on holistic approach. I remember, I don't want to name, he's my very, very close friend, a very, very senior, very, very renowned cardiologist of Ahmedabad. And he was saying that, Hemant, the problem is that, and I think I have seen that, as the senior, the internist going with little extra exposure in diabetes and non-invasive cardiology, that nothing wrong with having so many super specialists, because they definitely make the quality much better. No question about it. But in a patient who has got a nephrological problem, cardiological problem, neurological problem, the endocrinal problem, everybody will come and say, okay, do this, do this, do this, do this. So the problem is there is no holistic approach to the patient. And in fact, what happens? In ICU, many a times we say, I don't know if there is any reason, any way out. Maybe there is a way out, which we can discuss later on, is after the lecture is over someday, is, the confusion happens in the relatives. The nephrologist will say that the problem is with the kidney, this much problem. The cardiologist say, well, patient is in failure. Neurologist say, well, his sensorium is bad. So they just don't know what's going on. So what this cardiologist friend was telling me, and which I am saying, that who will connect the dots? There has to be somebody who has to connect the dots. Because patient is not isolated neurology. Patient is not isolated kidney. Patient is not isolated heart. Patient is a patient as a whole. And are we looking the patient as a whole? Perhaps no. And I think this is our biggest challenge. In the time when all super specialties are coming, it's good, but there has to be some common sense. There has to be some connection. There has to be some, kind of a sanity in seeing the patient as a whole. It's very, very important. So, two quotes I want to say. Once again is William
Sir,
Osler.
Time is up.
2 minutes. Because this is important. Would you allow me 2 minutes? Oh, I thought you were enjoying. It's more important to know what sort of a person has a disease than to know what sort of a disease a person has. I think remember this for your lifetime. And if you would become much better doctor. And if you have not read this book, I would strongly recommend to read Being Mortal by Dr. Atul Gawande. How many of you have read this? Anybody? Yeah, good, somebody. Atul Gawande's Being Mortal, you should write it down. And he says wonderful thing, which I have been telling anyway, is we have been wrong about what our job is in medicine. We think our job is to ensure health and survival, but really it is larger than that. It is to enable well-being. The time does not permit me. Abhishek is on my back, so I will not go further into that. And very fast, I'll go through, you can just see yourself why the people are dissatisfied. These are the several reasons the patients have actually put here. And you have to see where you can go. And our challenges are many. Either it's an emerging disease or Google syndrome or our own attitude towards our colleagues. I can't elaborate on that. And you go further is a high and at times unrealistic expectations. Patients want quick results, the non-acceptance of reality. And I think do something syndrome. I think, and this is what we found maximum during our COVID time, isn't it? Doctor, do something. Patient માં કશું એ ના હોય તો બી તમારે કંઈક તો આપી જ દેવું પડે. Do something syndrome. It's something very important. So last is very important, friends. I have been giving lecture of future of medicine, which is also liked by many. And what would be future? Would be robots, 3D printing, there would be biosensors, nanomedicine, genome sequencing, virtual reality, augmented reality, big data, pharmacogenomics, artificial intelligence, biomedical engineering. Tomorrow somebody will go and get the limb as if it's a OPD procedure. Beauty parlor ma jao chho, that will happen after 30-40 years. Go and get your limb. It's something like that. But my point once again, why I have put this slide is, even if with this much of advances, what will happen? The physician will have to be in the center. The physician's common sense will have to be center, because only physician will decide whether this particular thing is going to be beneficial to the patient or not. So friends, it is all up to you. The buck stops at you. We just can't keep on talking. The choice is yours. Whether you wish to be a doctor dictated by technology, or you want to be a doctor who treats patient with compassion, care, commitment, and common sense. It's all up to you. Thank you very much.
Thank you so much.